I am now pleased to introduce our first speaker, Dr. Donald Berwick. Don began his career as a pediatrician and is a leading authority on healthcare quality and improvement. He is a former administrator of CMS and currently serves as President Emeritus and Senior Fellow of the Institute for Healthcare Improvement, which he co-founded. Don also serves as an advisor to NIHCM, and we are so grateful he is with us today to offer his perspective on this important issue. Don?
Thank you so much, Catherine. It's an honor to join you on this very important topic. I'm grateful to NIHCM for teeing up what's going to be a fine session, I'm sure, with my colleagues Mona and Tom. My intention in the next 15 minutes, is rather breathlessly, is to introduce you to some of the science that we have beyond the problem of physician burnout. The bad news is there's a lot of burnout. The good news is we know a lot about what to do. About it. Definitions here, and I'll give you references shortly. Burnout is a syndrome characterized by a high degree of emotional exhaustion and high depersonalization. That means decathexis of the job itself, cynicism, and a low sense of personal accomplishment from work. You'll hear the word resilience used a lot, and the definition is here. Resilience refers here to the glue that holds groups together, provides a purpose larger than the solitary self. You're part of something bigger than yourself, and allows entire groups to rise to the challenge. As you heard from Catherine's introduction, we have some bad problems with burnout in healthcare. They pre-exist COVID. Rates of burnout among doctors, nurses, and nurse practitioners and physician's assistants are relatively high compared to other job occupations, and they have been for years. These data are nearly 10 years old, and you can see the high levels of burnout. And if you compare physicians to the overall population for burnout rates and for satisfaction with work-life integration, physicians turn out to score rather poorly compared to the population at large. And as Catherine said, COVID has made it worse. Burnout rates now in the COVID era approach well over 50%. For physicians asked about their current state of mind. The consequences are severe. The slide comes from the Mayo Clinic book that I'll be showing you shortly, but it catalogs all of the downstream effects of physician burnout and loss of resilience, both for the individual physician and for the physician in their professional role. The consequences for patients and patient care are also serious. For example, in an area I'm very concerned about, medical error, there's a 2.5-fold, a 220% increase in medical errors in the work of good physicians who are burned out. Now, the science I'm going to be sharing with you has a lot of pedigree. I want to call your attention to these two recent books, which to me create a gold mine of opportunity for those of you interested not just in documenting burnout, but learning what to do about it. The first it's got to be the instant classic in the literature by Swensen and Tait, Shanafelt, Strategies to Reduce Burnout, 12 Actions to Create the Ideal Workplace. I'll be sharing with you quite a bit from this book in the few minutes ahead. The National Academy of Medicine has also had a ongoing project on burnout, clinician burnout, and it included this very seminal report on clinician burnout, which appeared last year from a consensus panel report. The stuff I'll be presenting to you comes from both of these documents. The first scientific point I want to make is that you can measure burnout. Christine Maslach, 40 years ago, developed what's known as the Maslach Burnout Inventory. It's not just specific to healthcare, but it's very pedigreed, it's well documented, it's easy to use. It is long. There are 50 items in the Maslach Burnout Inventory. Steve Swensen and Tait Shanafelt proved at Mayo Clinic that there are 3 items which basically capture from that inventory most of the variance you're going to see in the overall score. An index of emotional exhaustion, a question about emotional exhaustion, a question about cynicism or depersonalization at work, and a question about self-efficacy, a sense of being able to have an effect on the condition of the patients and the workplace. So those of you interested in getting serious about this in your organizations, I will tell you this is just one among several well-pedigreed instruments that can be used to study and measure and track burnout levels in your organization. I mentioned the National Academy of Medicine project. This is a major project I believe has been going on over 3 years now. It's an action collaborative on clinician well-being and resilience. Several key figures from American healthcare are leading this, and it's a rather large campaign. I assume that if you will be in touch with the National Academy of Medicine, you too can become more involved with this very important platform for leading, I believe, now even more so to a national campaign to improve clinician well-being. The goals of that IOM Action Collaborative, of National Academy Action Collaborative, is to raise the visibility of the problem, to understand the sciences behind the challenges, and to advance solutions in concert with the people as part of the collaborative. I'm showing you this model, which I know you can't read it on the screen here or make use of it, but each of the major researchers in the arena of physician burnout have produced models of the factors that underlie well-being, resilience, and burnout. This is the model that was generated by that National Academy of Medicine report, which is now used as an action framework for organizations and policymakers to think about moves that will help improve clinician well-being. Most of the rest of what I'll be showing you comes from these two absolutely key researchers who were involved with it and remain involved with the National Academy. On the left is Dr. Steve Swensen from Mayo Clinic, Intermountain Healthcare, and now back at Mayo, and Dr. Tait Shanafelt, also at Mayo Clinic, originally now at Stanford. Steve and Tait are, I would say, the thought leaders in this field, the people that have done the most disciplined research, and they've done it for a decade. They did it long before SURF was up on this problem in the COVID pandemic. I mentioned frameworks you will find in Tait Shanafelt's work at Stanford, the Stanford WellMD model of professional fulfillment. Again, there's more here than you can digest. These slides will be available to you, and you can check out Tait's work. But if you want a framework for action on burnout and well-being, the Stanford model is strong. And the Institute for Healthcare Improvement, the organization that I used to lead and now senior fellow at, has produced a downloadable framework for producing joy in work, which is the positive side of the challenge of working on burnout. And there is a lot of action going on at IHI. I urge you to get on the IHI website if you want to see ways to join the Institute for Healthcare Improvement activities on joy in work. I want to take the last couple of minutes to show you the framework that emerged from Steve Swensen and Tait Shanafelt's work at Mayo Clinic. This comes from their book, and I strongly commend it to you. Steve has redacted their results into 4 areas of action for organizations or individuals that want to work on burnout and resilience, or as they put it, flourishing. And they're rather interesting categories, highly actionable 4 categories. They all cycle around this central model of conditions for flourishing. They're called here by Swensen and Shanafelt agency, coherence, and camaraderie. This comes from 40 years of research, and especially decades of research on self-determination theory, studies of core human needs that are not just anti-burnout, but pro-flourishing. Agency refers to the capacity of individuals or teams to act independently, the sense that I can do things. Coherence is a sense that you're part of something larger than yourself, and camaraderie is a matter of social capital and interaction. And you'll see these 3 play out in this model that Mayo Clinic produced. The first of the 4 areas you may be surprised about. It's called removing pebbles. It has to do with the concept of leadership taking action to remove small hassles from the work of the workforce all the time, every day. The constant removal of small obstacles to getting one's work done through it. The framework that Swensen teaches is listen, sort, empower. It's just a framework for rapid cycle improvement of removing pebbles. And it involves just what it sounds like it involves. It's identifying what's hassling people trying to do their work to get through their day. And then as a leader, as an executive, as a manager, understanding what those hassles are and simply removing them constantly with feedback to the workforce on that job. In the Institute for Healthcare Improvement, we ran a project in our Leadership Alliance, which you all are welcome to join. There are 55 organizations in it now. But 2 years ago, we ran a project on stupid rules that stand in the way of patient care. 85% of those rules turned out to be non-regulatory. They're perfectly within the capacity of organizations to change things to make it easier for the staff. 24 of the 55 organizations produced a list of 360 stupid rules in 1 week. And the entire project then got devoted as to stopping requirements to do stupid things in the work of patients. The results of the work on Pebbles is astounding and well documented. Well documented in cluster randomized trials. This is systematic research done at Mayo Clinic. A 21-point reduction in burnout. That's not a 21% reduction in burnout. That's a 21-point reduction in the Maslach scale score. Highly positive results for satisfaction and teamwork simply by organizing leadership energies to remove little hassles in work. This is testimony from a doctor and nurse partner at McKay Hospital in the Intermountain Healthcare System, who basically conducted in their team in the ICU removing Pebbles project. They had astounding results. 6 months after that project began, they had reduced rounding times in the ICU from over 7 hours to an hour and a half. Understand what that does to the conditions and motivation and sense of empowerment of the workforce. And it can be done right there at the front line as long as there are leaders willing to facilitate removing of Pebbles. This next slide shows you a resource you can have. The American Medical Association has set up a steps forward online access model built on the Shanafelt and Swensen model, in which there are tutorials linked to every one of the 4 elements I'm showing you. This is the tutorial for the Pebbles removal project. The only thing you need to notice is if you get on the American Medical Association website and look at the steps forward modules, you'll be able to do self-study on these 4 areas. The second area is a surprise. It's Commensality. This comes out of research that Steve Swensen has done, and it is supported by 3 randomized clinical trials, all of which have results including reduction in cortisol levels, stress levels in subjects in at least one of the trials. It has to do with eating. When people in an organization or a group are able to spend time together relaxed in conversation where there are no boundaries, no rules, you can actually begin to let your hair down and share what's going on in your lives, especially around meals, believe it or not. There are remarkable results in reduction of stress and burnout. There's a project that I'm involved in called Bongo. You can get on the website for bongomedia.com, which is using this idea of conversation in very small ways within organizations to help people simply talk with each other. Very simple change. Dr. Christine Sinsky at the American Medical Association, by the way, has picked up on all of this, and that's why the AMA now has the Steps Forward tutorial. This is the tutorial on commensality. The third of the 4 areas in the Swensen and Shanafelt models, they call job crafting. It's a little harder to explain, but it has to do with an observation that one of the most important aspects of that triad of meaning in your work and agency, coherence, and camaraderie is that people are able to do in their jobs things that mean something to them instead of nonsense. Job crafting is the senior management undertaking to do as much as you can to restore elements of work in the job descriptions and opportunities that workforce has to do the stuff that means something to them. Clinicians that spend at least 20% of their time doing what is meaningful to them have half the burnout rate of those that say they do not. 20% of your time, 1 out of 5 hours, if you can invest in a workforce that says at least 1 out of 5 hours, I'm able to do work that means a ton to me, you get far lower burnout rates. And the fourth of the 4 categories is leadership behaviors, and this has been very well documented by those Mayo Clinic researchers, by Tait Shanafelt now at Stanford University. There's a more complex story here I don't have time to tell you, but there was major research done originally at Mayo Clinic, validated now elsewhere, studying the relationship between specific leadership behaviors and burnout in the workforce. At Mayo Clinic, the study was originally of 41 department chairs. They expanded to 3,300 care leaders in the Mayo Clinic system and overseeing 65,000 staff. And the question was, what do leaders do that reduce burnout? And the answer is 5 things. This comes from very systematic research, which you can access in the book. But when leaders engage in behaviors that are inclusive, treating everyone with respect and nurturing a culture where everyone feels welcome, when they're informative, they transparently share what they know with the team, when they constantly inquire of the team how things are going, when they invest in professional development and aspirations of staff, and when they just express gratitude. 5 simple, almost obvious leadership behaviors, but highly variable in the Mayo Clinic data, even among the original 41 department chairs. Enormous variability in the degree to which they engaged in these behaviors. The association between those behaviors and burnout levels was profound. I've hardly ever seen correlation coefficients of the magnitude that Swensen and Shanafelt reported in this study. The scale that they used involves just 5 questions, which elicit these 5 behaviors. The maximum score you can get is 60 points. So the leader with the highest possible score on all those behaviors gets a score of 60. A 1-point change, 1 point out of 60 in leadership behavior on those 5 variables, recognition, inquiry, information, developing, and inclusion, increases fulfillment scores 11% and decreases burnout scores, that Maslach scale, 7%. This is profound impact of very specific leadership behaviors on burnout levels. Again, the American Medical Association Steps Forward module has ways for you to dig more deeply into the research here. This all goes back to one of my mentors, W. Edwards Deming, who focused heavily on these issues framed in terms of joy and work, said people are entitled to joy and work, and said management's overall aim should be to create a system which everybody may take joy in their work. In the work of leaders like Steve Swensen and Tait Shanafelt, and in the pioneering work now going on at the American Medical Association and at the National Academy of Medicine, you now have a scientific foundation for pursuing and reducing burnout and increasing resilience. Thanks for the chance to share these ideas with you, and I look forward to the specific comments we're going to get from Mona and Tom, and to your questions. Thanks a lot, Catherine.
Thank you so much, Don, for sharing these insights and research that help inform how stakeholders across the healthcare system can support clinicians and their well-being.